Hi, I'm Dave Farnell, digital editor with Health Imaging, and I have with me the SNMMI president, Munir Ghassani. He is the chief of nuclear medicine at Mount Sinai Health and associate professor of radiology at the Icahn School of Medicine. He is an expert in PSMA PET, and I wanted to talk to you a little bit today about this new technology and that's created an awful lot of excitement, both in oncology and in radiation oncology.
Well, first of all, thank you for the introduction and thank you for the opportunity to have this discussion. It is an exciting new technology that is in many ways changing the way overall prostate cancer is managed. And I can, without any hesitation, see that the literature that will evolve from its widespread use in the coming years is going to have a quite different management algorithm for prostate cancer in the future as opposed to what has been done historically.
What's so game-changing about it? Is it just that it's more sensitive, so you could pick out more of the tumors, or especially if they have metastatic disease?
Yeah, so if you take the example of or some of the terminologies, for example, what's called biochemical recurrence of prostate cancer. Historically, it was oftentimes when the patient's PSA would go up, especially on a multiple time points, and it would leave very little doubt that there is a recurrence of cancer. But if you do a traditional imaging, including CT, MRI, bone scans, and you don't find it, you have to manage them very arbitrarily. And there are some empiric treatment options that were applied. But now that we have the technique available, oftentimes we find that the cancer is seen in small lymph nodes that are only 2 or 3 millimeter in size. And those lymph nodes were not suspicious enough on a traditional imaging sequences to call them positive. And now that we know even a small amount of tissue can be harboring the cancer, now you can do a specifically targeted treatment. As you mentioned earlier, that the excitement is similarly seen in the medical oncology community, but also in radiation oncology community. And the reason is that if you now find, let's say, what we call the pelvic sidewall lymph nodes, if you find that that's where that cancer is located, in addition to giving the salvage radiation treatment to the prostate bed, they also include those lymph nodes, and that improves the outcome of the patients. The other way it also helps is that sometimes the cancer is not seen in the traditional area, for example, in the pelvic sidewall. So we have seen a number of examples where a radiation oncologist would have drawn the treatment volume based on the expected pattern of recurrence. But then when we find that the cancer has been in the areas outside of that radiation therapy coverage, by providing that information, the radiation oncologists are now recalculating and redrawing their planned treatment that makes sure that those lymph nodes are captured in that treatment algorithm. So the likelihood of success is higher when you have appropriate tools available to do the therapy that includes all potential areas of cancer spread.
And I'm guessing with the PSMA PET that it probably makes contouring and doing your treatment plans a lot easier when these tumors, these very small tumors, light up like a Christmas tree.
Right. Not only it makes contouring easier, but it also makes sure that the contour is all inclusive of all potential areas where the cancer may have spread.
And while there's been a lot of excitement about this, the FDA has approved this technology. What is it replacing, and what really is the standard of care today, and how much does it really differ from this new technology?
Yeah, so that's a very important question. We are still in the transition point, but I can see the evolving pattern of workup would be that it may, in many instances, will not require to do a CT scan and a bone scan before going for PSMA PET. And so much so that if you look at the most recent NCCN guidelines, they already have mentioned very specifically that the PSMA PET is so powerful that it may not even require the initial workup with bone scans and CT scans in the appropriate setting. So it will clearly, I can see that 3 to 5 years from now, bone scans and CT scans will be not used as frequently or very minimally as compared to what it is the current practice right now.
And in terms of the agent itself, is this something that's produced locally in a cyclotron on site, or is this something produced at a commercial cyclotron and driven in? What's the availability like?
So there are multiple options. Those academic centers that have cyclotron on site can potentially produce them. Of course, it will require appropriate licensing and regulatory approvals. But from the commercial supplier standpoint, which is majority of where these radioisotopes are available, that includes both generators as well as cyclotron production. And we are fortunate that our industry is recognizing the demand for this, and so our industry partners are ramping up the production capability and options, which is wonderful because in our practice we see a large volume of these scans, and we are not having any issues with the availability of isotopes. Even sometimes there are patients in our practice, for example, where some of our patients travel from out of state, out of country, and they're getting their scans done. And we have to request these add-ons at a very short notice. And we are able to get access to these agents even with a short notice.
And what's the half-life on the agent? Is this something that you can get a shipment in the morning and you're good for the entire day, or is this does it have a relatively short half-life?
It has a short half-life, and so that becomes a major logistic considerations. So the gallium half-life is about an hour, and the fluorine half-life is about 118 minutes, about 2 hours. So yeah, you have to make sure. So if you have number of patients scheduled scattered throughout the day, you need to have multiple delivery options. But what is again very encouraging is that there is growing network of the radio pharmacies and their locations that are available. Now, obviously, we still have work to do, and there are certain remote community hospitals and rural settings where we need to still expand the network so that patients across US are able to access these agents. And from that regard, we still have work to do. But the good news is that our industry is keeping those considerations in mind and strategically placing the locations so that they can meet the needs throughout the country.
And you mentioned that you could also produce this isotope using a generator. Is that something that might be an option for rural hospitals or further outliers?
Yeah.
How many of these agents are cleared?
So currently, between gallium and fluorine, there are 4 FDA-approved options.
Do you have any gauge on where things might be at within the market or the industry with adoption of PSMA PET?
Compared to our historically previous agents that have been introduced in the market and their acceptability and their widespread use has been relatively slow. And compared to that, the PSMA PET was very quick to catch on in the clinical use. And it speaks to several factors. First of all, we have built on the successes of the previous agents that have been introduced and how powerful they have been. So there's already a certain degree of acceptance and faith and reliance in our clinical colleagues that nuclear medicine techniques in general are revolutionizing the management paradigm of very many cancers. And in the future, also for other applications such as infection and inflammation. Same way, cardiology community is very well aware of how powerful some of these PET agents are. So that's number one. Number two, the number of articles that have been published prior to the approval of the agents for PSMA PET have been quite remarkable. So there's already this building enthusiasm amongst our clinical community, even prior to the first PSMA approval of the agent. And the urology and the GU oncology community is always on the forefront of what's new and what's promising. And we find that they are very eager to keep an eye on what's new and exciting that may be game changer in their treatment paradigm. And they are very quick to adapt to anything that has been of proven value. So I think if you combine all those factors, I'm not surprised that the volume of number of cases that we are doing is quite high. And that has been the case whenever I speak with my colleagues in other parts of the country. They are sharing the same degree of enthusiasm about the acceptability of the PSMA PET-CT.
Are there any other aspects of PSMA PET that you think it's important for peers to know about if they're thinking of adopting the technology?
Yeah, so one of the early, this is yet needs to be proven, but what we are finding that not every biochemical recurrence of prostate cancer spreads in a systematic way. And so, prior to a widespread use of these agents, it was believed that whenever the cancer spreads, it usually spreads through the venous plexus, going up through the channels into the retroperitoneum, we call. So there was an expected pattern of spread. In a small minority of the cases, it skips all of those areas, and we find in very unusual sites of the disease in the chest, for example, that you traditionally would not scan. So many times the prostate cancer patients, when they are suspected of recurrence, the typical imaging algorithm covers the abdomen and pelvis. But if you don't include the chest, you sometimes would miss the actual presence of disease there. And we have had a number of times when we would see them and we would present them at the tumor boards, and the clinicians would often end up biopsying those sites. And it would turn out to be true representation of the disease. And they would always make it a point telling me that if it was not for a PSMA PET-CT, we would not have known that this cancer has spread the traditional route of spread of the disease and has gone to some unusual areas. Now, obviously, this is not very common, but nonetheless, for individual patients in whom this happens, it does help in management of the disease appropriately.
Great. I appreciate your overview.
Thank you.